Vineet sir back to the stage. And just to let everyone know, this session is sponsored by AstraZeneca.
Thank you. And now switching gears from ovary to prostate. These are the first line management updates in metastatic CRPC. So all of us know that prostate cancer has the second highest incidence and the fifth leading cause of cancer related deaths amongst the males. And at the best, you see, when you see across the trials, whether you use abiraterone, whether you use enzalutamide or docetaxel, you are looking at about 20 months, 25 months, or probably 30 or 32 months. Not more than that when you talk of metastatic CRPC. And these are the trials here in which you have docetaxel, abiraterone, and enzalutamide. But if you see the real life scenario, it mirrors it. So you have around 2 to 3 years when you talk of survival in these patients. And the treatment options are primarily based on phase 3 randomized controlled trials. And you can see they are cabazitaxel, enzalutamide, abiraterone. Then olaparib was also there, and you have the combination of these drugs which are there. If you have only bone metastasis, then probably you can add radium-223 to these patients. So there is an association with the BRCA mutation and poor prognosis disease, meaning thereby those patients who have BRCA mutation in metastatic CA prostate, they are the ones who are going to have a poorer prognosis, albeit as compared to those who don't have. And if you see the NCCN guidelines, when you continue treating these patients, you find that if the patient has a adeno-CA, you bring a plethora of drugs. So you can have all kind of combinations. One is if you have no prior docetaxel and you have no prior novel hormonal therapy. So then in these cases you can execute enzalutamide, abiraterone or docetaxel. If you have had a prior novel hormonal therapy or a prior docetaxel, then probably you can get the novel hormonal agents. Plus you can have the theranostics in which you have lutetium, and you can institute the second line taxane, that is cabazitaxel. So all these combinations which are there, and there was a study in which it was seen that could we combine olaparib and a novel hormonal agent and see what would be the benefit. So this was the study 8. In these patients, docetaxel was already given, and it was unselected group. So as you see in the PROFOUND trial, it was a landmark trial in which you could delineate which are the patients which have the HRR, which are going to actually benefit from treatment. So these are basically the BRCA1, BRCA2 mutant and ATM positive. So if you have these 3 mutations, these are the ones which are going to come under the maximal purview of treatment with PARP inhibitors. So taking a cue from that, it was thought that why not do a study in those patients who are unselected for any mutations and combine it with the novel hormonal agents like abiraterone and see what is the overall picture which comes out. So the radiographic progression-free survival was the one which was taken in this, and the secondary endpoints were the overall survival and the secondary PFS. And there again you found that there was a difference, that is about 5 months difference in the RPFS in these patients where olaparib was combined with abiraterone versus placebo, and only abiraterone was given. And there is a data to suggest that the RPFS, there is a benefit independent of any HRR status. So if you have a patient who doesn't have any mutations these patients can also be brought under the purview. And there are multiple trials which are investigating this concept. And you have the first trial, which was the profound trial, and after that you have had a plethora of trials in which multiple drugs like talazoparib, rucaparib, and veliparib have been used for investigating this. So the question comes that why do you want to combine abiraterone with the PARP inhibitor? So it has been reported in animal studies that there is an induction of the HRR, an increase in the susceptibility to the PARP inhibitors when abiraterone is added to the PARP inhibitors. And simultaneously, the PARP inhibitor inhibition that has been reported to increase the activity of the abiraterone. So you have a synergistic effect between these two, and that probably is the reason why these have been used, and they are beneficial in those patients who are not having any mutations whatsoever. So this was the first phase 3 study, PROPEL study, which was presented last year in ASCO GU, and this was to see the benefit of the study 8 which was done prior, the efficacy of combination of a novel hormonal agent with a PARP inhibitor, whether it adds anything to the PFS, that is the radiological PFS or not, and of course is there any overall survival benefit. So the patients who were enrolled to PROPEL had a HRR status determined retrospectively by the tumor tissue and the plasma ctDNA sampling. So you had a plasma ctDNA sampling also, and you had a tissue sampling also for the HRR. And these were the baseline characteristics which were evenly matched in the abiraterone alone arm versus the abiraterone plus PARPI arm. Tumor tissue testing was the gold standard to assess the HRR, but failure rate of 30% was seen in the PROPEL study, which was similar to the PROFOUND study. As you can see, the HRR unknown, there is about 30% discordance when you see the tissue versus the plasma ctDNA. So that was accounted for, and this demonstrated a median 8.2 month improvement in the radiological progression-free survival in those patients who had combination of abiraterone and the PARP inhibitor, which was olaparib. So the median PFS was about 24 months versus 16 months, which was having a hazard ratio of 0.66, which is very robust. And it also demonstrated a median 11.2 month improvement in the blinded independent central review. So you had the study review and you had an independent review. Both were mirroring the same in these patients. And the updated radiographic PFS is by the ITT. You can see that there is again a difference between those patients who were given abiraterone alone versus the combination. And this was seen across the groups, as you can see in this forest plot, irrespective of the site of metastasis, irrespective of the fact that they were given docetaxel prior or the baseline or the HRR status. You find that all of them are favoring the olaparib and the abiraterone side as compared to abiraterone alone. Coming to the key secondary endpoints, there was a trend towards the OS benefit, as you can see at the data cutoff 2, and this trend will be subsequently seen probably at a later date, but there is definitely a radiological progression-free survival. The other endpoint was the time to first subsequent therapy or death. Here again you can see that the curves for the TFST show separation, although it is just a 50% maturity. Probably in the later timelines this will be alluded to. The quality of life indices, you can see by this FACT P total score, you find that there is no much decrement in the quality of life in those patients who were given these combinations versus only abiraterone alone. And again, this was consistent with the investigator assessment, meaning thereby that there was a meaningful improvement in both the HRR positive group and the HRR negative group. So, safety profile, you find that if you see the abiraterone arm and you see the combination arm, there is not much difference between the adverse events, and the dose interruptions and the dose reductions were almost same in both the arms. And again, if you see the side effects profile, the ones which we see with the PARPI inhibitors, the key side effects which are anemia, fatigue, asthenia, and mild amount of transaminitis, this was seen and it was concordant with the known profiles of the drugs. There was no major change when you made a combination of these two drugs. So the PROPEL trial is a new thought process in which, one, you are seeing in HRR negative patients, two, you are combining a novel hormonal agent, that is abiraterone, with the PARPI inhibitors in unselected population. This is not any mutant population, and still you are deriving a benefit of about 7 to 8 months. But this is the radiological progression-free survival. The events are not matured for the overall survival, but I think in times to come, if you have a RPFS of 8 months with a hazard ratio of about 0.6, then probably you'll have a survival benefit also. So switching gears again from PARP inhibitors, again in the relapse setting you have lutetium. So this was the VISION study, in which this was an international randomized open label phase 3 trial, which was in those patients who were lutetium PSMA positive on the PET scan. And this was this was the schema in which lutetium was given for 4 cycles, and this was 200 millicuries, and this was given over a gap of 6 weeks, and after that there was assessment of the radiological progression-free survival and also the overall survival in these patients. These are the baseline characteristics. They are equally matched, and these are the results, and these show that definitely there was an improvement in the RPFS in those patients who had an avid disease on the PSMA PET scan, and when they were subjected to lutetium as a part of the theranostics, they had benefit in the RPFS. The adverse events again were not very much. You had the derangement of the kidney function test. There was mild myelosuppression in these patients, and of course constitutional complaints were there like asthenia. There is another study, this is the THERA-ANZUP study, in which this was again the combination, whether those patients who have been subjected to docetaxel prior, instead of giving cabazitaxel, can we give the lutetium therapy. So this was again the lutetium which was pitted against cabazitaxel, which was the current standard. And again here the primary endpoints was the relapse rates and the PSA progression. You find that if you see these waterfall plots, the one which is on the extreme left side, that is with lutetium, that is showing a much better response as compared to the one which is with the cabazitaxel. So again, this is another new thought, that contrary to the primary thinking that if the patient has docetaxel and has progress, that we give cabazitaxel as the second line. This is a more targeted approach in these patients, and definitely the response rates are much better when you see the radiographic progression-free PSA survival. So whenever a patient goes from a hormone sensitive to a CRPC status, the standard choices which we have is, if the patient has taken docetaxel earlier, we switch over to the novel hormonal agents like enzalutamide or abiraterone. If the patient has PSMA avid disease, these patients can be given theranostics, that is lutetium therapy. If the patient has only bone disease, then these patients can be subjected to the radium 223. And now this trial, the PROPEL trial, has shown that in the intent to treat population in those patients who are unselected for HRR, a combination of a novel hormonal agent like abiraterone with PARP inhibitor like olaparib can give you a decisive radiographic progression-free survival. And contrary to the thought process that if you have a progression on cabazitaxel, on docetaxel, you give cabazitaxel, then probably if the general condition of the performance status of the patient is not that great or cannot tolerate cabazitaxel, then probably you can think of lutetium therapy if the patient has a PSMA avid disease on the PSMA PET scan. So I thank you for your patient hearing.
Dr. Talwar, fantastic presentation from your side. Two things are in my mind and I want to know your opinion. By your presentation, is it like something by defect that we are trying to make a sequence of the docetaxel followed by abiraterone plus olaparib followed by the novel hormonal agents like enzalutamide or darolutamide for that matter? Is it something like that?
No, this is a totally different thought process. You have the radiographic progression-free survival. The OS is not yet matured. So till the time the OS is not matured, if a patient wants to switch over to a novel hormonal agent, you can see that there is a difference of about 7 to 8 months if you combine the PARP inhibitors with the novel hormonal agents. So in times to come, if you have the actual OS benefit, this could be a practice-changing study. Not at this point of time. And
okay.
Another thing I would like to say, if a patient has progressed on docetaxel in the hormone-sensitive setting and comes to the hormone-resistant or the CRPC setting, these patients should not be subjected to docetaxel again, because the GITAC trial has shown that it becomes a negative feedback for the signal transduction. So if you want, you should not re-challenge docetaxel even if the time interval is more than 1 year.
And suppose if the patient is HRD positive and by any reason patient is not able to take the combination of the abiraterone plus olaparib or cannot afford or tolerate olaparib, then is the cabazitaxel plus platinum is a good option in this scenario?
Oh yes, definitely it can be explored like the way it has been explored in ovary, but that will be on select case-to-case basis. You can't take it across the board.